Gracias, Joaquin. And buenos dias to all of you, ladies and gentlemen. It's really my great pleasure to have a chance to speak with you this morning about a program that my colleagues and I have developed over the last 35 years, developed and tested. And it's a program that sits at the intersection between health and social services. It's a program that begins at the earliest points in human development, soon after conception, and it's a program designed for vulnerable families, following them through pregnancy to the child's second year of life. I personally became involved in this work in 1970 when I finished up undergraduate school and went to work in an inner-city daycare center in Baltimore, Maryland, in the U.S. I hoped that if I could just help poor preschoolers get off to a good start, that they would have a better chance of succeeding in elementary school and later on in society. But for many of the children in my classroom, it was too little and too late. One little boy, for example, had been born to a mother who was an alcoholic and a drug addict. She had abandoned her child with friends in the drug culture, and he was in my classroom, but he couldn't communicate. He only, with words, he only gestured. And I realized that he was being cared for, by the way, for a wonderful grandmother, but his life prospects were severely limited by his exposure to alcohol and drugs during pregnancy. Another little girl in my classroom I suspected was being sexually abused. One little boy I witnessed being slapped across the face and yelled at as he was brought to my daycare center in the morning. One little boy couldn't sleep at nap time because he was afraid, because he wet himself when he slept. And if he wet himself, his mother beat him. So I realized that we needed to help parents develop their skills in caring for their children, and that we needed to start much sooner. I set up programs for the children in my daycare center for parents to come in the afternoon while their children were taking naps to talk about their children's needs. And what struck me was that it was the parents of children I was least concerned about who showed up for those parent group meetings. It was the parents that I was most concerned about whom I never saw. So I eventually went to graduate school and developed the program that we're, let me say this. We were concerned about parenting behavior, but in all of these interventions that focus on early parenting, I think it's very important that we pay close attention to the contexts in which parents have to care for themselves and care for their children. In our daycare center in inner-city Baltimore, there was a great deal of emphasis on the importance of eating a healthy diet. But for miles around our center, there were no supermarkets with fresh fruits and vegetables. The rates of unemployment were off the charts. The housing stock was terrible. The park where I would take children was unsafe. The rates of crime were extraordinarily high. I had my car stoned on the way to work in the morning. So while we believe that parents' protection of themselves and protection of their children is really crucial to healthy development, it's important to pay attention to those conditions in which parents have to live in designing effective interventions, we believe. So after going to graduate school, and my colleagues and I developed the program that I'm here to talk with you about this morning, known as the Nurse-Family Partnership, or in the UK, known as the Family Nurse Partnership. Again, it's a program of prenatal and infancy home visiting by nurses for low-income mothers having their first babies. We think that this focus on first-time births is really crucial because families are going through this critical transformation in their own roles in life that make them more receptive to offers of help, which I'll tell you about in just a moment. We think another key feature of the program is that it is designed with an underlying theory that says that all of us as human beings are instinctually driven to protect our children, and that if we dig deeply enough, we will uncover that instinct, and that we can activate it and support it. And to the extent that we are activated and supported effectively, the likelihood of transformed caregiving, protection for children will be enhanced. We think that the program has also been successful for two reasons. One of them, for other reasons, and one of them is that we're clear about what we're trying to accomplish and how we're going about accomplishing those goals and objectives. So the nurses have three major goals. The first is to help parents improve the outcomes of pregnancy by helping them improve their prenatal health, cutting down on the use of tobacco, alcohol, illegal drugs, improving diets, helping women identify emerging obstetric complications that can complicate the developing fetal brain, that can compromise the developing fetal brain. And so the second major goal is to improve the children's subsequent health and development by helping parents provide more competent care of the baby, beginning during pregnancy and following through the child's second year of life. And the third major goal is to help parents become more economically self-sufficient, not unlike what Ian Duncan Smith was talking about earlier this morning. The key in all of this, we think, is to help parents start developing a vision for what life might be like, and to start imagining what they might do to better protect themselves and their children, and to think about how completing their educations and finding work will help them become better providers of care for themselves and their children. And critical in all of this is starting to think through how the timing of subsequent pregnancies may affect their abilities to stay in school, find work, care for that first child. So all of these elements of the intervention around helping families become more economically self-sufficient are integrated. And to the extent that each one of these goals is accomplished, it strengthens the likelihood that the other is going to be accomplished as well, because children who are born with fewer exposures to tobacco and alcohol are more likely to be better regulated in their behavior early in infancy, making it easier for parents to care for them, and so forth. So you can start to see how each of these elements of the intervention come together to reinforce one another over time. Actually, I think I'd like to take a moment and give you some sense of what this intervention looks like on the ground with real families. One young mother who was visited by a nurse came to her first visit visibly depressed, smoking cigarettes. And her nurse asked her, when she saw that she was smoking cigarettes, whether she was planning to cut down on the number of cigarettes that she was smoking now that she was pregnant. And this young mother responded, "You know something? This baby has taken everything else away from me, and it's not going to take my cigarettes away too. And you know something? If you say anything else that I don't like, I'm going to slap you across the face." You think I'm kidding? I broke a couple of my mother's ribs in a fight with her just last week. This young mother went on to admit that she had harmed babies whom she babysat for. And she said to the nurse, "And I'm afraid that I'm going to do this to my own baby, that I'm going to harm my baby, especially if my baby is a crier." So the nurse came back after this visit with this young mother and said to the rest of the team, "I know that this young mother is off the charts in terms of her risk for abusing or neglecting her or abusing her child, but I think I can help her. And the reason I think I can help her is that she's essentially asking for help. And so this nurse returned to this home and said to this young mother, what would happen if you, after you deliver your baby, and you came home and your baby were crying in the middle of the night, is there anyone you could turn to for help, day or night? And the mother's response was, well, I certainly I couldn't turn to my own mother or anyone in my family, because it turns out that this young mother had been tortured as a child. But she said, and the nurse pressed on and said to her, is there anyone else you could turn to for help? And she said, yeah, there's Grandma Smith, we'll call her, who lives down the street. And the nurse said to her, well, do you know Grandma Smith's phone number? And she said, yes, I do know Grandma Smith's phone number. So the nurse wrote the number on a card and put her name and taped it on the wall beside the phone and said, you need to, here is Grandma Smith's phone number, so that when you return from the hospital with your baby after discharge, you'll remember where her phone number is in case this ever happens. That is, your baby is crying and you don't know what to do. It turns out that when this young mother did, the baby was born prematurely, but the mother went to the neonatal intensive care unit every day after school to visit her baby. And after the baby was discharged from the hospital, she moved in with Grandma Smith down the street and lived with her for 6 months until her boyfriend got out of jail. And he started coming to visits. And the nurse started asking him about what his life had been like as a child growing up. And he revealed that he had been also abused as a child. And the young mother looked over at him and said, you know, we never talked about this, but I had been abused as well. And he said, this is really important, and I'm coming to these visits, and ended up showing up for visits on a regular basis. And together, they ended up managing the care of this child remarkably well, in spite of terrible, terrible circumstances. So even in cases where there have been terrible histories of maltreatment and in terrible social circumstances, we have case examples that give us confidence that the nurse can break through all of that past history and connect with families around this instinctual drive to protect the child and to support parents' efforts to care well for that child. Now, we're talking here about evidence today. We can't use these kinds of case examples as a simple kind of illustration of how the program works. But I think it's important to understand in real terms how the program may bring about changes in really difficult circumstances. Now, we've tested this program in 3 separate scientifically controlled studies over the last 35 years. And by scientifically controlled studies, we mean that families are offered participation in a study, and families agree to participate with the understanding that they may be randomly assigned to receive the intervention or to receive comparison services. And so that has been the principle that's guided each of the scientifically controlled studies that I'm going to describe for you today. And in each of these trials, we have had high rates of participant engagement, community engagement in the studies, high rates of participant retention, so that the estimates that we make of the difference between those who are assigned to receive the intervention or to comparison services the estimates are valid. That is, any difference that we see between the control services and the intervention services can be confidently attributed to the effects of the intervention itself, not some biasing characteristics. We've tested this program first with low-income white families in Elmira, New York, in a semi-rural community in New York State. Many people, after we published the results that Joaquin mentioned earlier, said, you have a program that works, you need to make it more widely available. We took the position that we ought not to do that, because we needed to know that the findings that we had found in our first trial would apply to minorities living in major urban areas. So we chose not to replicate the program in policy contexts, but rather to conduct more research. Many people, by the way, use the results of our trials to promote all kinds of home visiting programs in the U.S. And we chose, and we didn't know whether the findings from our trials would apply to all types of home visiting programs or whether they were limited to the particular program that we had tested. And I'll turn to that subject in just a moment. Our second trial was conducted in Memphis, Tennessee, with a large sample of African American families. Many of the benefits from the original trial conducted in Elmira, New York, were limited to families where there was concentrated social disadvantage. That is, where mothers were low income and unmarried, for example. And so in our second trial, we actively recruited families who were almost all living in poverty, where the mothers were unmarried and where there was concentrated social disadvantage. Our third trial was conducted in Denver, Colorado, and by that time, many people had been promoting home visiting programs throughout the country, the U.S., using the results from our two previous trials. And they were often using paraprofessional home visitors, that is, people who were hired from the communities who shared many of the social characteristics of the families that they were serving. If you looked at the scientifically controlled trials of programs that were using paraprofessional home visitors, the results are actually quite disappointing. And we didn't know why that was. Is it because there is something limiting in having people from the community conduct home visits in these ways? Or was it because the programs themselves were insufficiently developed, and that if we simply provided paraprofessional home visitors with well-developed programs, that their impacts would be improved? I mean, there's a reason to believe, there's a theory out there that paraprofessionals might do better than nurses in serving vulnerable families. They share more of the social characteristics with the families that they're serving. As a result of that, families may identify with them, may feel more comfortable opening up their doors to them. And so we felt that it was important to conduct a scientifically controlled study in which both nurses and paraprofessional visitors had a well-developed program and were compared to a control group that received comparison services. And in the Denver trial, both nurses and paraprofessional visitors operated using the same program model that had been tested in our two previous trials in Elmira and Memphis. And one of the other advantages of the third trial in Denver was that it included a large portion of Hispanics in the study. Now, this slide shows you those outcomes that we have greatest confidence the program can affect, because we see replication of these impacts in at least two of the three trials. So we are confident that the program can have an effect on women's prenatal health, especially helping women reduce their use of tobacco. Tobacco is the most widely abused substance in pregnancy in the U.S., and it's one of the most damaging. It has clear impacts on fetal growth. It contributes to alterations in brain development that undermine children's capacities for behavioral regulation, increases their problems with impulsivity and attention problems. So tobacco use is really important to target. We also found in our first trial that there were significant improvements in women's diets and reductions in 2 trials in the rates of hypertensive disorders of pregnancy. We've seen significant reductions in children's injuries early in life. And that's important because, at least in the U.S., injuries are the leading cause of death among children aged 1 through young adulthood. We've seen significant reductions in the rates of subsequent pregnancies and increases in the intervals between the births of first and second children. We've seen significant improvements in women's participation in the workforce in the second year of the child's life, when challenges with childcare become less significant. And in our first 2 trials, but not our third, we've seen significant reductions in families' use of welfare and food stamps. We think that the absence of effects in our third trial on welfare and food stamp use, by the way, we don't see effects on employment in our third trial either, has to do with the fact that in the United States, in 1996, the U.S. Congress passed the U.S. Welfare Reform Act, which put lifetime limits on families' use of welfare. And in the mid-1990s through the early 2000s, there was a period in the Western world where there were periods of economic growth. We may remember that, some of us. And the result of that was that, at least in the U.S., you could get a job by walking into any establishment. You could find a job, and so there were these disincentives for use of welfare, and at the same time economic growth, so that people could find work. And so we don't see impacts on employment and welfare use in our third trial in Denver, and we think it has to do with these differences in the policy environment and economic conditions. But we do see replicated effects on children's school readiness and school achievement. These effects, though, are limited to children born to mothers with what we call low psychological resources. By low psychological resources, we mean that women have higher rates of depression and anxiety and limited intellectual functioning themselves, and they have limited sense of control over their life circumstances. It's these mothers who are least capable of protecting themselves and protecting their children in conditions of concentrated social disadvantage, where the rates of toxic stress are much higher, and where parents are challenged in protecting themselves and protecting their children. So we see significant improvements in children's language development, intellectual functioning, executive functioning, that is, their ability to focus their attention, to have reduced impulsivity, to organize their thoughts, to anticipate challenges. These are crucial cognitive skills that make a difference in children's school achievement. But it's limited to those children born to those mothers who are more vulnerable because of their own limited psychological resources. Okay. Now, in our first trial conducted in Elmira, New York, we found about a 48% treatment control difference in the rates of state-verified reports of child abuse and neglect. In the slide in front of you, you see that there is a bar, a histogram, that shows the rates of maltreatment for a group of families where the mothers were visited during pregnancy alone, not following up after delivery of the child. So I didn't tell you about that group in the earlier description of the Elmira trial, but that's what's represented in this slide. This treatment control difference that you see in this slide is even more pronounced when the analysis is focused on families where the mothers were at greater social disadvantage because of their being unmarried or their being from low socioeconomic households at registration. That's important for us because it conforms in general to a pattern that we've seen earlier in that is where we see that the impacts of the intervention tend to be greater where there is more social disadvantage. Okay. But we were very pleased to have the 48% reduction in the rates of state-verified reports of child abuse and neglect. Do you have a pointer? Do you think that points? Okay. But we asked the question, why is it that we didn't eliminate child abuse and neglect altogether? And we conducted analyses to help us understand for whom the program was not working. Because when we think about these kinds of interventions, they are not universally effective. And if we're going to move forward our abilities to address the needs of vulnerable children and families in our society, it's important that we understand not only for whom the interventions work, but for whom they don't work. Because if we can identify those for whom it doesn't work, hopefully we can devise better interventions to address the needs of those for whom it doesn't work. And what this slide is showing us is that 48% treatment control, nurse control difference in the rates of state-verified reports of child abuse and neglect was really limited to those households where there was no intimate partner violence or domestic violence or low levels of intimate partner violence or domestic violence. And when violence between partners accumulated or was higher, the impact of the intervention was reduced. We've been troubled by this finding for some time.
Este resultado nos lleva preocupando bastante tiempo y nos ha llevado a desarrollar nuevos programas de intervención que estamos probando ahora para ver si podemos conseguir mejores resultados para ayudar al personal de enfermería a abordar la violencia por parte de la pareja en estos contextos, que es un tema difícil de abordar, por una parte porque por supuesto hay un peligro. Sabemos que las mujeres tienen un mayor peligro de ser lesionadas o asesinadas cuando ellas mismas están en relaciones de maltrato, o sea que esto no es algo que se pueda tomar a la ligera. Y además no hay ninguna intervención basada en la evidencia todavía en el mundo que haya demostrado una verdadera efectividad en la prevención y el tratamiento de la violencia de género. En esta diapositiva tenemos resumidos los resultados de un estudio de seguimiento que llevamos a cabo y publicamos hace unos años, estudiando la incidencia de detenciones entre los niños y adolescentes del MIRA hasta los 19 años. Y en general hubo una gran diferencia a lo largo de todo este seguimiento en el número de detenciones. Pero si no analizamos, vemos que para los 19 años la diferencia únicamente era en las chicas. Lo que muestra esta diapositiva son curvas distintas del número de detenciones para cada grupo de edad, para los chicos en las curvas azules de arriba y para las chicas en las curvas rosas de abajo. Y en cada uno de esos grupos de edad tenemos unos intervalos de error que nos muestran el intervalo de detenciones para cada una de esas edades. Con lo que vemos ahí es que, en general, el impacto del programa, sobre el número de detenciones a los 19 años fundamentalmente se observa en las chicas. Previamente habíamos publicado efectos en el número de detenciones hasta los 19 sin diferencias significativas en los dos géneros hasta los 15. Así que en el estudio de Memphis decidimos concentrar la muestra en familias de madres solteras con niveles de pobreza muy importantes en las comunidades. La mayoría de estas jóvenes madres eran adolescentes y vivían en algunos de los peores barrios de Estados Unidos. Eran madres que tenían que enfrentarse a altas tasas de criminalidad, pobreza, desorganización social y al mismo tiempo criar a niños. Y sabíamos, por análisis previos que habíamos realizado en Memphis, que no íbamos a ver impactos en la tasa de denuncias verificadas de malos tratos, porque las tasas basadas en el análisis que habíamos realizado antes del estudio eran tan bajas que sabíamos que no íbamos a poder notar efectos usando denuncias oficiales. Lo que no sabíamos cuando diseñamos el estudio fue que uno de los motivos por los que había unas tasas tan bajas era porque el sistema para identificar o detectar el maltrato infantil no funcionaba. Y otra cosa que quiero decir sobre este estudio en concreto es que realizamos el estudio en Memphis porque pudimos inscribir a casi toda la población a través de una sola clínica, a través de la Universidad de Tennessee y lo que se llama el Centro Médico Regional de Memphis. Y el programa fue llevado a cabo por un departamento de sanidad del condado. Y el programa se llevó a cabo en el peor momento de la falta de enfermeras en el sector, con lo que nos abandonaban en mitad del estudio, dejaban el trabajo. Y esto nos preocupó mucho en su momento en cuanto a poder detectar impactos beneficiosos del programa. Pero ahora, por lo menos, nos hemos dado cuenta de que fue importante que fuera así, porque así el programa se estaba llevando a cabo en condiciones reales del sector. Con lo que los resultados que se hayan medido en el estudio se pueden atribuir a otros programas con otras poblaciones de alto riesgo en Estados Unidos, sean cuales sean las condiciones del programa. Como he dicho, no esperábamos ver impactos sobre el nivel de denuncias oficiales de maltrato y abandono infantil, pero sí que pensamos que veríamos efectos sobre el número de traumatismos y lesiones por el historial médico. Y otra ventaja de trabajar en esta comunidad con este estudio fue que teníamos acceso a todos los historiales médicos de todos los niños, porque todos recibían la atención a través de un único sistema sanitario, con lo que podíamos estar bastante seguros de cuáles eran los niveles reales de traumatismos, tanto con asistencia en consulta ordinaria, en urgencias, etc. Vimos una reducción del 23% en los tratamientos por traumatismos o ingestiones durante el primer año de vida. Pero lo que es más importante, hubo una reducción del 80% en el número de días de hospitalización por traumatismos o ingestiones o ingestas. En la fase posparto del estudio, asignamos desproporcionadamente a las familias al grupo de control o al grupo de tratamiento. Es decir, el número de familias asignado al grupo de tratamiento fue de 220. Y lo que vemos en esta diapositiva es que hubo 3 niños que fueron hospitalizados por heridas o ingesta de objetos en el grupo de tratamiento. Todos ellos tenían 12 meses de edad o más, o sea que eran ya móviles. Algunos andaban ya, otros gateaban y cogían objetos del suelo y los ingerían, 2 de ellos. Este niño fue hospitalizado por una quemadura en la cara después de haber cogido una plancha y a ver si le aplicaba la cara de alguna manera. Y en esta diapositiva vemos el grupo de hospitalizaciones de los niños del grupo control. Es importante ver que hubo el doble de niños hospitalizados en el grupo control, pero además un 44% de los niños del grupo control que fueron hospitalizados tenían menos de 6 meses. Con lo que no eran niños que gateasen ni andasen, estaban pasando otras cosas. Un 58% de los niños del grupo control fueron hospitalizados con traumatismos graves, con traumatismos craneales, hemorragias subdurales, fracturas de huesos largos, situaciones que, si nos preocupa el maltrato infantil, consideraríamos gravemente sospechosas, con lo que, aunque no pudimos ver el impacto del programa en cuanto a denuncias oficiales y verificadas de maltrato, sí vemos el impacto del programa en el historial médico de los niños. Y esa diferencia del 80% entre el grupo tratamiento y el grupo control en el número de días de hospitalización por lesiones graves o ingestas de objetos se limita a aquellos niños nacidos de madres con pocos recursos psicológicos. Es decir, lo que representan estas curvas son estimaciones de la relación entre días de hospitalización en este eje y recursos psicológicos de la madre para el grupo control y para el grupo visitado por enfermeros. Y esta escala, que incluye depresión, ansiedad, función cognitiva, sensación de control de las circunstancias de la vida, está estandarizada a una media de 100 y una desviación estándar de 10. Así que esto lo que nos indica es que toda esa diferencia del 80% entre el grupo de tratamiento y el grupo control en días de hospitalización de los niños se ve de forma muchísimo más clara en los hijos de madres con niveles de recursos psicológicos más bajos. Es decir, son las madres menos capaces de proteger a sus hijos y en algunos casos sospechamos que son las causantes de esas lesiones que sufren los niños. Y para cuando los niños del estudio Elmira tenían 12 años, vemos diferencias modestas pero importantes en sus resultados de lectura y matemáticas medidos directamente. Y este efecto sobre la lectura y matemáticas se ve fundamentalmente, una vez más, en los hijos de madres con menos recursos psicológicos. Los niños de madres con recursos psicológicos mejores están más cerca de la media nacional en lectura y matemáticas, tanto en el grupo control como en el grupo de tratamiento. Y en el grupo de tratamiento, los niños de madres con menos recursos psicológicos están también más cerca de la media nacional. Para los 12 años vemos reducciones importantes en el consumo de tabaco, alcohol o marihuana. Los índices son bajos en general, pero son 3 veces más altos en el grupo control que en el grupo visitado por enfermeras. Y si vemos los niños que comunican síntomas de depresión y ansiedad, las tasas de depresión y ansiedad clínicas son un 40% menores en el grupo tratamiento que en el grupo control para los 12 años. Y en esta gráfica vemos el gasto público para ayuda alimentaria, subsidios y atención sanitaria pública. Medicaid es la atención sanitaria financiada por el Estado para los pobres. Y lo que vemos aquí, en estas curvas, son los cálculos de los costes a través de esos tres servicios sociales para el grupo control y los costes para el grupo de intervención. Son datos todos derivados de estadísticas estatales de Tennessee, que es donde se llevó a cabo el estudio, y la diferencia es de unos $12.500 de ahorro a lo largo de la duración del programa en comparación con un coste del programa en Memphis de unos $11.500. Así que en estas tres áreas de gasto social se amortiza ampliamente el gasto del programa solamente en esos tres programas de cobertura social. Esto nos parece muy positivo, pero también somos conscientes de que la mayor parte de estos cálculos son anteriores a la reforma del sistema en Estados Unidos, así que no estamos seguros de si ahora se obtendrían los mismos resultados con las actuales políticas. En esta diapositiva vemos esencialmente los resultados, o resumen los resultados del tercer estudio realizado en Denver, y vemos que las enfermeras producen efectos similares a los que habíamos visto en los programas anteriores, en Denver y en el MIRA, mientras que las familias que son visitadas por semiprofesionales están a medio camino entre las familias que no reciben ningún apoyo y las que reciben un apoyo profesional. Así, por ejemplo, aquí vemos los cambios en cotinina, en orina, a lo largo del embarazo, en el grupo control, en el grupo de intervención con semiprofesionales y en el grupo de intervención profesional. La cotinina es el principal metabolito de la nicotina y lo utilizamos como marcador del consumo de tabaco por parte de las madres durante el embarazo. Y vemos una diferencia muy significativa entre el grupo control y el grupo asistido por enfermeras, y no hay diferencia significativa entre el grupo control y el grupo asistido por semiprofesionales. En esta diapositiva vemos los plazos hasta el siguiente embarazo en el grupo control, en el grupo con asistencia semiprofesional y en el grupo asistido por enfermeras. Y vemos que hay una prolongación significativa hasta el siguiente embarazo en las familias visitadas por enfermeras, no tanto en las visitadas por semiprofesionales, y la diferencia entre el grupo control y el grupo visitado por semiprofesionales clínicamente es significativa, pero estadísticamente no lo es. Y para cuando los niños están en edad preescolar, con 4 años, en el estudio de Denver, vemos mejoras significativas en los niños visitados por enfermeras en los resultados obtenidos con una escala de lenguaje preescolar, no en el grupo visitado por semiprofesionales. Y estos efectos, como en el estudio Memphis, se ven fundamentalmente en los niños de las madres con menos recursos psicológicos. No se ve diferencia en los niños de madres con mayor nivel, con mayores recursos psicológicos. Y la diferencia entre el grupo asistido por semiprofesionales y el grupo control en este estudio a los 4 años es clínicamente significativa, pero no estadísticamente significativa. Y vemos el mismo tipo de diferencia cuando medimos la función cognitiva. Aquí vemos una combinación de su capacidad de concentrar la atención, recontrolar su impulsividad, y vemos reducciones muy significativas en el grupo visitado por enfermería y no en el grupo visitado por semiprofesionales, aunque yo diría que esta diferencia en el grupo intermedio es clínicamente significativa, aunque no sea estadísticamente significativa. Y el Instituto del Estado de Washington para Estudios de Política Económica, del que nos hablarán después, ha calculado que el impacto económico por familia, combinando todos estos estudios, es de unos $13.000. es el ahorro que se consigue con este tipo de intervenciones. Y desde 1996 hemos estado ayudando a otras comunidades de Estados Unidos a desarrollar estos programas ya a mayor escala y no solamente para la investigación académica. El Departamento de Justicia nos ha pedido que desarrollásemos el programa en zonas de altos índices de criminalidad. Hasta ese momento no habíamos llevado a cabo el programa, excepto para la investigación, por dos motivos. Primero, porque no sabíamos si la efectividad iba a ser bastante como para que estuviese justificada la inversión pública. Y por otra parte, porque no sabíamos si el programa era ya lo suficientemente operativo como para poderlo ampliar y duplicar en otras comunidades. Decidimos que había llegado el momento de dar ese paso y lo hicimos con muchas dudas. Finalmente creamos una ONG que se llama Nurse Family Partnership o Alianza Enfermera Familia, que se dedica a trabajar en estas áreas para garantizar que el programa se lleve a cabo con la máxima calidad. Pensamos que la aplicación correcta requiere que estén en su lugar los recursos necesarios, porque sin esos recursos no es probable que el programa tenga éxito. Nos hace falta primero asegurarnos de que la comunidad y las organizaciones sean las apropiadas para llevar a cabo el programa. El programa también aporta servicios técnicos y de asesoría para el personal de enfermería para que se les pueda ayudar a desarrollar las habilidades necesarias para llevar a cabo el programa. Hay unas directrices además muy detalladas, visita por visita, que luego las enfermeras adaptan a las necesidades individuales de cada familia, pero con una estructura que se puede utilizar. También hay un sistema al que se puede acceder por Internet para introducir datos y que nos permite a todos entender hasta qué punto el programa está cubriendo y alcanzando sus objetivos y sus metas. Y lo utilizamos para ir adaptando de forma continuada lo que se está haciendo en cada comunidad para mejorar los resultados del programa y también para entender a nivel del sistema y la metodología cuáles son las dificultades y los elementos del diseño del programa que habría que modificar para que fuese más efectivo.
Okay, so we're. Yeah, that's okay. Let me talk about this.
A lo largo de estos últimos años nos han invitado para montar un programa fuera de Estados Unidos y al hacerlo hemos adoptado un planteamiento y es que realmente no sabemos si el programa va a funcionar bien en España o si va a funcionar bien en el Reino Unido o Alemania u Holanda o con los aborígenes, por ejemplo, en zonas muy lejanas de Australia. Así que pensamos que tenemos que ser colaboradores y que tenemos que trabajar con otras sociedades para llevar a cabo una adaptación sensata, para trabajar bien con las familias de sus países y que tenemos que llevar a cabo también pequeños estudios para asegurarnos de que todo funciona según lo planificado. Y tenemos que pasar hacia un estudio randomizado de más envergadura en esas sociedades para que estas sociedades puedan generar buena evidencia acerca de si es una inversión adecuada o no para su contexto. De tal modo que llevamos haciendo este trabajo en el Reino Unido y Kate Bellingham va a hablar un poco más adelante sobre lo que hemos hecho en su país en los últimos 6 o 7 años aproximadamente. También hemos hecho lo mismo en Australia con las familias de aborígenes. En Canadá, la British Columbia también ha invertido mucho en el programa e ha incluido un estudio randomizado a gran escala. Y hemos estado trabajando con las tribus del norte de Minnesota, las tribus de los indios, para adaptar el programa a esos lugares. Y también pensamos que tenemos que reconocer que el programa va a estar en evolución permanentemente, que tenemos que ser rigurosos respecto a su diseño e implementación, pero supongo que tendremos que ser humildes también acerca de los límites de sus efectos. Y hay que pensar que no solamente hay que crear las condiciones favorables para la implementación, sino el propio modelo del programa tiene que ser mejorado, como sucede en el campo de la violencia que he comentado anteriormente. Así que tenemos que innovar continuamente y tenemos que desarrollar métodos rigurosos de verificar estas intervenciones a medida que montemos un modelo más efectivo del programa. Con el paso del tiempo, tenemos una serie de programas de investigación que se están llevando a cabo en Estados Unidos, cuyo objetivo consiste en mejorar estos aspectos que no voy a detallar precisamente, pero lo importante en este caso es que reconocemos o sabemos que nos queda mucho trabajo por hacer y que nuestro éxito a largo plazo para conseguir mejorar el programa dependerá del tipo de compromisos y de colaboraciones que se den con los profesionales y los legisladores en las diferentes sociedades. Pero este compromiso compartido debe permitirnos implantar un programa de alta calidad, con una ciencia de alta calidad, para poder desplazar el dial para aquellas familias que están más comprometidas con la ayuda. Muchas gracias.